Good afternoon, everyone. I'm just going to give everybody a few minutes to get settled and log on, and then we'll get started. For everyone who's just arriving, we're going to get started in just a moment. I'll just give you time to get settled and log on to Zoom. Okay, so we may get more arrivals as we go on, but I'll just begin with a little bit of an introduction. Thank you for everybody who's here for joining us today. My name is Rennie and I'm a counselor at AGI. And if you're joining us for the first time at AGI or Alzheimer Groupe, we support people who are living with dementia and those who support them through programming for people living with dementia, counseling and support groups for caregivers, and education. So today's lecture is being made possible by the generous support of the Lindsay Memorial Foundation. I just want to make a couple housekeeping notes before we begin. Please keep yourself on mute throughout today's lecture. If you have any questions for the presenters or you have any comments that you'd like to share, please write them in the Q&A box, the chat box, which you can find along the bottom of your screen, and we will be sure to address them. I'll make sure it gets read aloud at the end of the lecture or whenever it's appropriate. So today's lecture, A Guide to Palliative Care in Quebec, is part 1 of 2. Part 2 is going to be held on April 22nd, so stay tuned for that. And just a note as well, you will be able to get a copy of the slide deck that our presenters are using today, so you can refer to that after today's lecture. So without further ado, I would love to introduce our speakers that we are lucky to have here today. We are joined here today by Zelda Freitas. Zelda is a social worker and the coordinator of the area of expertise in caregiving at the Center for Research and Expertise in Social Gerontology, CREGES. And she has extensive experience in the provision of psychosocial care to adults in loss of autonomy. Zelda is a member of the Council on Palliative Care since 1998, offering educational presentations on topics related to caregiving issues, grief and loss, and access to care. She has been recently named as an adjunct professor at the McGill University School of Social Work. And we are also lucky to be joined today by Patrick Durivage. Since 1999, Patrick has been interested in the elderly population receiving palliative care. For many years, he was an accredited regional trainer and runs trainings for professionals on clinical tools related to loss of autonomy. He has contributed to the creation of various trainings and manuals on palliative care. He is part of the McGill Council on Palliative Care, a not-for-profit organization that educates the general public about palliative care. In 2015, Patrick was appointed at the Quebec End of Life Commission. I'll now hand it over to you, Zelda and Patrick. Again, if you're attending today, you can feel free to put questions in the chat throughout the lecture, and I'll make sure to address them when we can. So Zelda and Patrick, we are really all looking forward to learning from you today. Thank you.
Thank you, Rennie, and thanks for the Alzheimer Society to invite us to present today on a topic on palliative care, but specifically to the end-of-life law that's been in place since 2015. So welcome all, and this presentation will be co-chaired and co-animated by me and Zelda. So here we are today.
Just a quick correction there, Patrick. I know it was a little bit of a slip of the tongue, but it's the Alzheimer's Groupe and not the Alzheimer Society. Just to make sure we're talking to the right to the audience we plan to today. So I'm just going to jump in then. We're going to jump back and forth a bit. So hopefully we'll do that in a very coordinated way, as we usually do. Today we're speaking to you from the Center for Research and Expertise in Social Gerontology. We wanted to touch base just a little bit about who we are and what we do. So we're the coordinators of the areas of expertise. As you see on the screen, there are 4 areas of expertise. I'm the coordinator for the caregiving expertise. So what we do is we work work with researchers, and we validate and develop and test leading edge practices that will help enhance practice, and also do quite a bit of teaching and knowledge transfer activities. We have another area of expertise that's called inclusion, aging, diversity, health, and well-being, which is very large, but it really incorporates a lot of the activities around the inclusion of older adults in community and in everyday life, and what are some of the challenges that they face to make that happen. I'll hand it over to Patrick.
Yes, and Zelda is the coordinator of the leading practices in caregiving issues. So I'm the coordinator of the community palliative care for seniors, specialized with seniors. And we have another also area of expertise, which is countering mistreatment of older adults. So we have a provincial line on elder abuse prevention. This area of expertise has been in place for the last 25 years, so it's well known, and it's we're happy to have them on board with us.
So just in terms of the presentation, just to touch base on that, we will be presenting today the first part. There are 4 components to the law. So today we'll be talking about advanced medical directives and access to palliative care. And of course, we'll leave some time for some questions, and because we'd really love to hear from you and hear your questions. The second part will be next month, and then we'll be talking about continuous palliative sedation and specifically about medical aid in dying. And again, having a brief period of time for questions as well. So like Rennie said, if you have questions, if there's anything that's not clear and you want to communicate with us throughout the presentation, please put that in the chat, or speak to Rennie directly, and we'll be very happy to clarify anything that may not be clear in the presentation as we move forward.
So today we're going to use a case study presentation to kind of illustrate the progression of a disease. And of course, we took Alzheimer's disease today to kind of illustrate the different steps and phase of the disease, and linked with access to palliative care today. So today we'll start with access to palliative care with a little description of the law, and then we'll move to the advanced medical directive. So the law on end-of-life care was passed in 2015, put in place in 2015, which encompass like 2 major components that we mentioned at the beginning. So there's the rights of the patient at end of life, and the organization and the framework on how that end of life care is provided through the CSNCUS, which is the health organizations we have in Quebec, which encompass, well, of course, palliative care and continuous palliative care sedation. Palliative care sedation will be presented next week. So today we'll focus on palliative care and advanced medical directives, and then part 2 we'll discuss medical aid in dying. So as you heard in the news, there's been some modifications with on the federal level. So we're happy that's in the next presentation will be in a few weeks. So we'll have enough time to gather all the information and guidelines that are coming up in Quebec to see how it's going to apply in Quebec. So we're kind of relieved that the presentation will be in the next few weeks, so we'll be able to update the info that we have right now on that topic. In terms of what's important to remember about the law, the core value of the law is really self-determination. So this is a key component of the law. That's kind of the value that's behind the law, which really looks at the patient's choice of getting the right care they want. Especially with dementia, it could be a bit tricky, though, however. So if it's possible to have that conversation before the patient's much advanced and with the dementia, will help the caregiver to navigate the care and to get the service at the right moment. So that's tricky, and we'll keep that in mind in our case presentation to help you to when is the right moment to request palliative care, when is it the right moment to ask your family doctor to see if it's appropriate to request palliative care at that moment. So we'll keep that in mind with the case study. And but we also are very cognizant of your reality as a caregiver in navigating the healthcare system and to request service at the right moment. So that'll be true throughout the course of the 2 presentations. So, like I mentioned, the Law 2 is based on the right of the individual and really looking at the importance of the organization and the management of the care that's provided at the end of life, and looking at the wish of the individual while considering also the caregiver's perspective. So the advanced directive allows a person to request or to deny care they would like to have in the future, but we'll talk a bit longer. Zelda, you have something else to add? No? Okay.
No, I think if we move to the next slide, I think it'll be a little bit clearer in terms of, as with any law, there is always a governance and a structure that comes with law. And so I think it's really important, we think it's really important that people understand the structure of this law so that you're well informed about how it could impact your particular situation. So, you know, the law covers a number of very important aspects that touch our lives and our individual choices, as Patrick emphasized. The governance of this law is the Minister of Health and Social Services. So it is the responsibility of the Minister of Health and Social Services to put in the structures that will support the different aspects of this law. So every health and social service agency, so every CIUS and CIS must have some governing structure in place so that people could access end-of-life care that is provided by the different institutions and the hospices and residences that are part of that CIUS and CIS. And each institution within the CIS and the CIUS has to also have an organizational plan and a clinical program that speaks directly to end-of-life care. And so whether you're operating a CLSC, for instance, or whether you're operating a palliative care unit or a palliative care residence, or a hospital, an acute care hospital, they all have to have in place an organizational plan that speaks directly to end-of-life care. So that's important. We really feel it's important that people understand that this is something that is there for you and for you to be informed of. Next slide. So providers of end-of-life care, again, we are talking about the 4 different components of the law. So any health network must provide end-of-life care. These are the provisions that are in the law. Palliative care residences can determine end-of-life care services that they offer on their premises. So this basically speaks to the fact that there are some palliative care residences that you might have heard of over the course of time since 2015 that have decided to opt out, for instance, of providing medical aid in dying. And so this is left to the individual center to determine what they can and what they are willing and able to offer within their own premises. It's also noted in the law that private practice doctors and nurses can provide end-of-life care at home. So again, I think that was something that needed to be clarified. We do know that there is a private healthcare system parallel to the public, and that there are private practice doctors that do home visits. So this is another provider of end-of-life care that's mentioned in the law as well.
Mm-hmm. So in the law too, what's different from all the other policies that Quebec came around in the last 30 years, it really recognized that people can have access to healthcare. It's now set and described in the law as a right. So a user that needs palliative care have the right to request palliative care or their caregiver. So it's really a game changer, and hasn't been discussed very much in the news or in the coverage in terms of this important aspect of the law. So Law 2, there's been a lot of emphasis put on medical and dying, of course, because it's a new care that's provided in Quebec, but not a lot discussion in terms of that. Law 2 recognize that people have access to palliative care, and it's in their right to request palliative care when it's clinically appropriate, of course. So it's really important to see that that element and look at, okay, there's documentation that exists. There's someone online, like Zelda was referring to the CIS and CIUS. They have to put their program on the internet and put some basic information. There's also 811 that could help you to navigate the healthcare system to get, okay, who's providing palliative care in my network. But also there's this document that's available online. It's called Rights of the Person and End of Life. It explains what is palliative care, what is different care, what it's built to, and it's written like in a way that's very accessible. So a very layperson type of description of what palliative care is versus creative approach versus medical and dying. So I know in Quebec the last few years there's been big focus on medical late and dying and end of life care, but there's the palliative care approach that exists that people have to be aware and when it comes to into play. Just as first warning, of course, with dementia, it's a bit difficult to estimate when palliative care begins. It's part of the disease trajectory that somebody will lose their faculty, not just cognitive faculty, but there'll be some loss of autonomy. At one point, they'll stop walking, they'll stop be able to feed themselves, they'll need more physical assistance. And even somebody who's kind of bedbound or not moving at all, they could live 6 months, a year or two in that condition before palliative care will begin. So it's tricky for caregivers to ascertain when is the right time to request palliative care, but that's something that you should discuss with your care team, your family doctor, your home care team, or your different specialist that your loved one is linked to see when palliative care should start. However, in Canada, in part of the North America, it's now considered that palliative care should be offered earlier on to patients with dementia. Dementia is a situation that's a condition that you're not able to cure. So therefore, we should start talking about dementia care with geriatric care, but also maybe a palliative care approach. We're not able to cure dementia, but we should compensate the different signs and symptoms and the different behaviors and use a bit more an approach that's suitable for those individuals and families. So the get-go, the learning that we want you to remember, or the key element of the law too, is that palliative care is a right, but for many, many patients out there, and especially patients with Alzheimer's disease, that it's difficult to access palliative care. And we'll give you some tricks on how to do it in the different care settings that we'll present later on. So you're entitled to request palliative care, and not just for seniors. So if you're an individual that's 14 years and older, you're able to request palliative care if your medical situation is required to request that type of care. A person can also request palliative care even though they refused it in the past. So even though that you refuse be followed by palliative care, you can still request it in the future and when you're ready to receive palliative care. Of course, it's a voluntary service that's very useful at end of life, and we could define what end of life means. It's not longer just 3 months time frame. It could be over a time frame of a year or two. So palliative care, it can be provided throughout the end of life. And of course, if you have difficulty to access palliative care, keep in mind that you're entitled to file a complaint with any commission of complaints in every healthcare system or establishment in Quebec. And that complaint has to be prioritized from the commissioner of complaint. So any complaint that regards end-of-life issues or palliative care access, the commissioner of complaints, they have a limited time to respond. For general complaint, they have a certain time frame. I think it's 60 days and that has to respond to you. But for any complaint regarding palliative care, they should respond much quicker, like within a few days. They should really respond to you and help you navigate to request palliative care if it's appropriate for your loved one. Zelda, you're going to talk about the Tidley family.
So these are, I mean, we're talking about the law and the stipulations in the law and the provisions of the law, and this is a lot of information to take in. And so what we wanted to do is try to walk through and journey through a possibly typical scenario that will perhaps bring to light some of the provisions of the law in more practical ways. So the Tilley family it's just a case example. It's a fictional case example. You want to just put on the first bullet. So it's basically a story of a gentleman of 77 years old who is diagnosed with early on stage Alzheimer's dementia, Alzheimer's disease. Typically being diagnosed in a geriatric clinic, they may be given some, medication to help with, slowing down memory loss. And he continues on with his regular activities with maybe a little bit more of an eye from his family members to see how he's doing. And he continues, for instance, maybe participating in some volunteer activities, again with the family sort of being have an extra eye on what's going on and how he's coping with this new diagnosis, and how everyone is as well. We talk about progressiveness of this illness. So with, say, 2 years time, we could make that perhaps a marker in that his situation gets worse, in that perhaps there is a sentinel event where he may have get lost on his way home from his volunteer work, so that we notice, the family will notice that there is a change in his situation, and his GP and recommends, for instance, at this point in time, still early on in the disease, an ID, some kind of an wandering ID bracelet of some sort, so that could help with the wandering, or maybe the possibility of him getting lost. So what we wanted to demonstrate is that there's this progression that's going on, that there's this disease that is taking over a little bit more and more space and worry in his family and in himself. Then we think about the possibility at this point that there are programs and perhaps activities that are starting to become involved in his life. And for those of you that are caregivers and family members, you have probably lived this kind of progression where it starts off slow, things happen, some events happen, more outside resources might be getting involved. So here we gave the example of Mr. Tilley being referred to the AGI DATE program by his GP. There is a little bit more cognitive decline. He continues to participate in some of his regular activities, but with some modifications. So maybe now his wife or his son might be driving him to the Meals on Wheels program where he volunteers, because he's still able to help out in the kitchen cutting up vegetables, but he's not able to maybe get there on his own, or they're concerned about that, or maybe someone goes with him. And so this is where now maybe he gets referred to the CLSC at some point in this trajectory, and the home care team gets involved. And it may be at this point in time, or ideally at this point in time, where we start talking about one component of the law, which is called advanced medical directives.
So in this situation, Mr. Tilley is still able to consent to care. His faculties are still okay, so he's able to understand what's presented in front of him. He's able to make that information. He's able to personalize information to himself. He's able to make some decision in terms of what he wants in terms of future care. So, of course, for advanced medical directive, it's part of Law 2, which is end of life. But advanced directives could be discussed at any time of life. If you're 18 and up, you could look at advanced directives and look at what type of care you would like to have in the future in a situation that you become INAP. INAP is being incompetent or not be able to decide for yourself because you don't have the cognitive faculties to assess the situation and personalize it to your own situation and make a good sound decision on the care that you would require in the future. So again, there hasn't been a lot of attention in media about advanced medical directive. The great part of it, advanced medical directive, it's kind of a vehicle so a person could express their wish in a form that's set by the government, and that you could have decide what type of care you want in the end-of-life context. So the advanced directive is really, it's a voice of the patient when they're not able to express themselves in certain condition. And we'll look at the condition, and we'll also look at the different care that you can consent or refuse. But again, if you haven't heard about it, it's quite normal. There's been a few publicity campaign, 2015, and there hasn't been a lot of media coverage about it to kind of encourage people to look it up and to do it. So again, there's a nice flyer that exists. You could download it from the internet and check. There's also different website that explains advanced directives. So this document is available in French and English. And in our PowerPoint, you'll have the different links to upload the different documents that we put in the PowerPoint. So advanced directive is really set in the law, but it's also, like I said, a vehicle that replaces everything else that's been in place. So if you draw a will where you set some directive for your family in terms of you don't want active care, you don't want any heroic measures at the end of life. If you have set with your family, perhaps living will, or if you set also maybe the document from Speak Up website to kind of elicit what you want in terms of care, that's all good. But the advanced medical directive is kind of formalized and it will surpass any directives that you set in the past. So once it's filled, signed, and sent back to the NQ, this document will be put in a computerized registry, while all the physician and some frontline workers will have access to really see what type of care you want and what you agreed or refused on. So it's really important to keep that in mind. It's also important that keep in mind that those directives could be modified throughout the year. So if you have an event, if you're hospitalized and you saw, okay, well, I received oxygen, I received an intubation, and maybe it was okay to consent to it. Maybe you change your mind and you want to modify your advance directive. It's possible to revoke it, and you just have to request a form and send back to the RAMQ to revoke the previous one. So the good part of it is it's a computerized registry where all patients could definitely send it and make it accessible. So when does it apply? You know, advanced directives, it's really for in a situation when the patient is not able to consent to care because of many situations. Of course, if you look at the bottom, you look at Alzheimer's disease. Yes, it could be a situation that when it's advanced, your patient is not able to consent for the care. So it's good at the beginning of the diagnostic of Alzheimer's disease to discuss that element with the patient, see what type of care they would like to have in the future. But if you unfortunately diagnose and it's your person is too advanced, of course, you're not able to fill those advanced directives. However, it's still important to consult the document and have that open conversation with your loved one and your family to see what type of care the person would have liked to have. So it's still important to do that exercise, maybe not have it signed or have it processed, but at least to have that conversation with the family and perhaps having your family doctor or one of the specialists to kind of answer some of the questions you may have. So the advanced directive will only apply or be used when you're confronted to end of life situation. So as the disease progresses, the advancement of disease will eventually bring your loved one into a situation where there'll be only a few months or a few weeks in front of them, and that's the moment when those advanced directives will be discussed. So if your loved one has also maybe in a coma state, or they were involved in a car accident and they lost all their faculty to consent, or they become in the coma state and the coma is irreversible, then advanced directives will be discussed with the loved one. So those are the type of situation when the advanced directives would be discussed with the family and also applied. It's very important to keep in mind that for as long as the patient is apt to consent, the treating team has to consult the patient in terms of the care they want. And the advanced medical directives only addresses 5 specific care. So for all the other care, of course, the physician has to consult the caregiver or the patient if they're able to consent to this care. So it's very important to keep in mind that it's only very specific moments when the advanced directives will be applied. And for some patients, it won't be applied at all because those care won't be pertinent for them. So let's look at the type of care which a patient could consent. So the patient is able to consent to cardiac pulmonary resuscitation, what we commonly use in the medical term CPR. So when you see a medical show, like if it's a New Amsterdam or if any type of other show that you see, they do those massage, they use those electric shock to start up the heart again. Well, this is what we call the CPR. And CPR is something that could help you to resuscitate and provide, they could definitely restart your heart. But in what condition will you be? That's something you'll have to discuss with your family doctor. Is it worth it to go through resuscitation? I'm not just talking about the broken ribs that you'll have with those massage, but in terms of the condition, in terms of the loss of autonomy. So that's really something that specifically you have to discuss with your family doctor or your treating team to see, well, is it something that's really beneficial for my loved one at the state that they are? So I cannot answer for you today in terms of what should we go with or not, but that's the discussion you can have with your family doctor and of course your loved one to see, is that something that's good and beneficial for the person that has a heart arrest. The other care is the ventilator assisted breathing. Of course, during the COVID, we definitely had a lot of discussion in terms of those ventilators or respirators that were kind of lacking in the healthcare system. So is it beneficial to intubate? Is it beneficial for the person to be kept on oxygen or on those machines? That's also, again, a discussion you want to have. And of course, some of the patients, they have to consider their own beliefs, values, and also sometimes religion could play into effect in terms of accepting or refusing certain care. So you really have to consent according to your own belief and what you believe that's appropriate for your own health and what you may consider in the future. So it's good to have that discussion with your family so they will be aware in terms of what type of care you want. So fill in the form is important, but also have that discussion with your caregivers. Hopefully you have more than one that could speak up to you and inform the treating team, hey, my loved one signed an advance directive, please consult it. The other care to consent is dialysis. Well, it's a treatment that helps to purify blood because their kidneys are not able to filter the blood and to keep the blood system going. So that's a type of treatment that's offered. There's some patients that are on dialysis for many, many years, and it's helpful, it's beneficial, but really keep in mind that dialysis is also to be offered at the end of life, and you have to decide if you want to go through it or not. And it could be very specific to your own health situation. The other two cares are very difficult for a lot of caregivers to consider, and it's forced hydration and forced feeding. There's been a lot more studies that shows, having that type of care at the end of life, in the end of context, like in the next few weeks or months, it creates more harm for the person because their bodies are shutting down. So to force hydration and to force people to be fed either through peg feeding, like not being fed orally, but through different tubings, it adds more pressure on the system and the body than what the body could digest and process. So actually having forced hydration could be very difficult for the body and could create more adverse reactions such as pneumonias, such as water buildup, and that's won't be beneficial for the quality of life for that person. So those are the specific care that the person consent. So it's 5 care and the 3 contexts that we mentioned earlier. So be at end of life and be either in a coma state or being with advanced cognitive decline, such as Alzheimer's, Lewy body disease, or other condition situation that could prevent the person to be able to consent to care. So those are the very specific care. And of course, today I'm addressing for the person with dementia, with Alzheimer's disease, but it's also good for caregivers to also consider their own advance directives. So a lot of caregivers are confronted to the healthcare system or have been witnessing the loss of a friend or family member, and they realize, oh, my friend went to CPR, and my God, I don't want that for myself. So it's also good for caregivers to even consider the advance directives for themselves. So why consent to those cares? Well, it's to help you but also help your families to be aware of the type of care you want. If you want all those cares possible, that's fine. But you'll have to keep in mind that all those level of care is pretty much an ICU setting. So it's the intensive care setting where you can be put on a respirator, where you can be monitored with your heart. So to have that type of level of care, it's more a hospital setting. So it's very hard to have that type of care at home or in a private residence or even in a nursing home. That type of care is really, it's more a medicalized, hospitalized type of setting. So when you consent to care, you also have to be cognizant of the care setting to which you are also consenting. So that's very important for caregivers and patients to consider. Okay, I may consent to all the care, but does it mean I'll finish my end of life in an ICU setting? So that's also something to consider and to discuss with your GP or your CLST home care team to really look at where that care is provided. And that may influence your decision also. Maybe you want to spend the last few days or weeks at home, and you may forego those treatments because they're not adding quality of life at your end of life status. So it's a lot to take in terms of advanced directive, because we haven't had that discussion in the general public. So you may feel that you're lost with that discussion, but you should really look at it's medical directives, it's medicalized approach, interventions, but it's also as a social care, I see mostly as a relational aspect in terms of where you want to have the care and how you want to finish your life. You want it more a hospitalized setting, or do you want more a home care setting? I'll just give you a concrete, not concrete, but a very personal story. My father-in-law wants all the care possible. He wants all the active care. He had 2 major heart incidents in his life. If there's another one that comes up, he wants to go to hospital. There's no question asked. Even at 88 years old, he still wants all the active care possible. So for him, he checked all consent care. And for the caregiver, my wife, it's for her, it's no brainer. If he has a heart arrest, 911, back to the hospital, and the treating team will have to deal with the situation and look at what the type of level of care that he's going to have. So be able to request medical directives. Then you have the form that's been done by the ministry that you could request, and we'll show you how later on. But there's been a lot of discussion in terms of be able to request medical aid in dying through that form. As we speak right now, it's not still possible. There is going to be a committee in the federal government to look at, okay, that possibly in the future, people may be able to request it. But as we speak right now, it's not in effect. It may take another year or 2 before that comes into effect. We don't know how fast or how slow it's going to move. There's the election coming down the road. There's many factors. There's still the COVID. So it's hard to predict when that'll come into effect. But there's some committees that will be formed to be looked at to be request medical and dying for Alzheimer's patient, and we'll give you more information on that topic at session number 2. So how to request it very rapidly. The easiest way, definitely, which I recommend my caregivers and patients I see, is to call just the RAMQ. And you have the phone number here. You call the RAMQ, you dial advanced directive, and then you need to have your RAMQ card with you because they'll ask you for it. They'll ask to confirm your identity, and then they could mail it out to you, and you receive it in the mail within a few days. It's pretty quick. And you need to consult your treating team, make sound decision. There are some information, there's some little pages on what the care is about, but there's also some information online which you can consult that could guide you in terms of, okay, what type of care that looks like. Then you have to have 2 witnesses sign the form, not to convince you to change your decision on, but really to make sure that you're the person that signed it and there's no pressure that you went through to sign it, and that you're still able to consent to that care. And then you mail it back to the RAMQ. But before you mail it, make a few copies for yourself. Keep it in your own records. Keep a copy at home. Give a copy to your family doctor. Inform your home care team or other healthcare team that you filled it. And keep a copy when you go also into a nursing home, because nursing homes and public nursing homes will ask you right at admission if you did sign your medical directives. So it's important to keep that. And inform your family and your caregivers that that was done. And caregivers could be friends, could be neighbors, whoever that's involved in your physical and medical care or personal care, they should be informed that it was done. Activity. So I think Remy is going to help us to break up into No, sorry. We decided that we're going to have an open discussion about this advanced directive. But if you have questions, because I think there's a few questions in the chat box that maybe you could answer before we begin the activity by itself. So Remy, is there any question that the audience has before we continue?
Sure, Patrick. So a couple questions that I think people have on their minds that goes back to something that you just mentioned is, if someone's in a situation where they maybe have never had any of these conversations about end of life planning, about advanced care directives with their GP, for instance, is that something that, they should insist on, or, a conversation they should, make sure they're bringing up? How does someone navigate that kind of situation?
Good question. Well, that type of conversation takes time, and we know that GPs are pressed with time. So when you take an appointment with either the secretary or whoever that you take the appointment, ask for a bit more time to discuss advanced directives. So the GP could allocate a bit more time for the session so they could answer the questions. So it's very important to have that open discussion if there's any questions that you want. I would definitely suggest the person to ask their form from the RAMQ, read the document. You could go also online. There's a Quebec.ca website where the advanced directives, there's some documents, there's some explanation in terms of the care. There's also AGI Loi that provides some information. And you could also download the flyer that we saw, that we shown on the PowerPoint that explains the advanced directives. So you could get that information first. And if you have specific questions with your own medical health, well, I think it's good to raise those issues with your family doctors. If you have one, hopefully you have one. And then if not, with one of the specialists. If you're diagnosed with dementia, you're probably either seen by a geriatrician or by a family doctor to have that diagnosis. So definitely have that conversation with that person to discuss the type of care that would be beneficial for you in the future. And of course, it's always hard to plan ahead. And this, you're not planning for a trip. That's easier, that's more fun. But discussing advanced directives takes time. You need time to reflect. You may also want to discuss with your friends what they looked at, what they consented, and to have that open discussion. But definitely, if there's some medical questions, I would definitely ask your GP. And if there's no GP at all, if there's no healthcare professionals involved, well, caregivers could also call 811 and speak to a nurse in full santé to have the discussion in terms of, okay, what that care really means. Is that really wise to have that care when my loved one's 90, 92, 93 years old and has a weak heart? So it's not the ideal situation because the nurse doesn't know your loved one that well, but the nurse has medical background to explain the different care and what it entails. So it's a scenario C of all that list. But definitely, if a family doctor is involved, they have an overview of the medical situation, and they could discuss frankly in terms of what level of care, not level of care, but advanced directive is beneficial or not for them.
I think what's important to add as well is that we have to inform ourselves. So as much information as you can find out for yourself about what these different directives are. And then, with your questions, approach your GP with some very concrete questions. So that way they could link your medical history with your questions and what information you already have. There's a lot of information online about these different acts, these different medical acts. So it's really important that you get good information and then you can formulate your questions around the information that you do have and approach your GP about that. I'm just a little concerned about time. So I'm wondering if there's any other questions in the chat about advanced medical directives, Rennie?
We do have a couple questions. I can
Shoot.
let you know about them if you don't mind.
Yeah.
So we have one question. Somebody's asking, can your grown children be your two witnesses?
Yes.
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 Thank you.
As long as they're 18 and up, there's not an issue.
Okay, thank you.
Yeah.
And yeah, go ahead.
No, I was gonna go ahead. Never mind.
Thank you. We have
Next question.
We have just one more question as of right now, and then I
Mhm.
do want to make sure you have enough time to finish your slides. But we have someone in the crowd who's asking, we have a mandate as part of our will. At
Mhm.
this point in time, my husband cannot do what you're suggesting. Is the mandate sufficient to achieve his wishes?
Well, in your mandate, it's written a very generic way. It's not as specific in terms of those 5 care. So of course it could guide you, because in the mandate it's set in a way that's more in terms of objectives of care. It's not specific to those 5 care that's listed in the advance directive. So but you could still do that exercise with your loved one and your family. It's okay, well, if that situation happens, what type of care are willing to accept or refuse, and the implication of it. So especially if there's many family members involved in the care, and some members are abroad, and it's it comes to a situation when the person is hospitalized because of a sentinel event or there's a heart incident. Of course, if you go to the ER, and their objective is really to stabilize you, so they'll start the procedures if you don't have advance directives. And there's another form where we look after the whole activity that's it's more set in terms of the level of care. And the level of care could be discussed with your family doctor, and you could write different type of care you refuse also. So there's another way to do that without the patient being part of the discussion.
I think the key though, if we talk about advanced medical directives, or someone mentioned in the chat, the living will, or advanced care planning, which is more general, which talks about values and preferences overall, including medical directives, is to really try to have that kind of conversation as early on in the trajectory of the illness, of course. Having said that, if those discussions did not take place in the particular situation that the person just named, when the person they're providing care for could no longer sign in advanced medical directives, they still might be able to participate in a discussion around different wishes and values. Or as Patrick said, you gather around the people that are important to that person and sort of say, well, what would he or she want? What do you know? What are some of the values that they hold dear to them? And what are the implications of having those directives done or not? And so that there is an honest and open conversation. And what's best is that families are not put in a situation where they're in a crisis and making these decisions, because we all know it's very difficult to make these kinds of decisions in a crisis type of situation. And that's what will happen. And there will be a lot of pressure on the family to make those decisions rather quickly. And so having these discussions beforehand is really important. And that's the key message, I think, for us today.
So if you had that discussion or not, it's important to maybe review it as the disease progresses. So because you may change your mind, the caregiver can change your mind. That's quite okay. Also, one element that we didn't mention, but those advance directives could be also done in front of a notary. It doesn't have to. You can still order it and do it on your own, and it's free. If you do it in front of the notary, of course, there's a little fee that the notary will charge, but it could be also done in front of a notary when you do your mandate or your will or other notarized document. But if you do it on your own, it's still valid. You don't have to have your family doctor to sign it off. It's your signature and 2 witnesses, and then you send that in. If you have done your advance directive, and if you have a mandate, and you have a will, and you have some differences in terms of directives, it's going to be the mandate. It will be the advance directives that will supersede all the other documents. So if you have done a mandate, or if you even have the mandate obligated, then the mandatory that's assigned in your situation will have to respect the advance directives, and the treating teams will have to abide with the advance directives, because that's the voice of the patient, regardless of any other legal documents. So that's very important to keep in mind, that advanced medical directives will supersede all your other directives that you could have written up over the years. So it's really your spokesperson when you're not able to speak at end of life. Other questions, or maybe you open up for pros and cons?
So as I just saw what Megan wrote in the chat, and that's true. You do not need to update your mandate if you want to change your advanced medical directives. You could just do it yourself. And I think another piece, I'm not sure if I heard you say it, Patrick, but I'll reinforce that, is that you can change your advanced medical directives. It's not written in stone, because that seems to be one of the concerns that I've heard from caregivers, is that, you know, once it's done, you can't do anything about to change it. And that's not true. You can change it and update it. New information comes out, new ideas, you have new preferences, you can update it and change it. And it's the last one standing in terms of these directives that will be respected and supersede anything else that you may have written before with regards to these particular directives. Okay.
And of course, there's like millions of medical treatments that the hospital setting could offer. So for the other care, of course, if the patient is not able to consent, they're going to look for either a spouse. That's the first level in the civil code. If the person is not able to consent, they'll consult with the spouse, then the children, and then any significant other that has an interest or the best interest of the patient at heart. So those are the level of consent power for what we call a proxy in the other province, but it's really important to keep in mind that yes, you may have advanced directives, but physicians are also obliged to consult family members. They can't just proceed with treatments without consulting and getting consent from the family members, the patient not able to consent. So it's tricky for physicians also to look at all the different treatment possible, but who's going to consent to those different care. So it's a challenge to, in the COVID and pandemic context on top of it, to be able to inform the caregiver and explain the medical situation in the ICU context or the ER context. Other questions? Because we have a little bit of a presentation before we wrap it up.
So yes, I just want to say thank you I think you've just answered these questions very helpfully. We don't have any further questions at this time, so I think it would be great if you can provide the rest of your information. Thank you.
So if we go, we'll just really quickly go back to the Tilley family again, looking at the trajectory. So Mr. Tilley is now involved with the home care team. They provide information about different options of care. So we're talking about advanced medical directives. We're talking about home care. We're talking about palliative care. We're talking about different options that are available for Mr. Tilley and his family. And at this point in time, he chooses, and his family supports him in the choice to remain at home for as long as possible. So this is a preference that he is able to express, and this will guide the practice and the rest of the trajectory of the illness in terms of how the illness evolves. That value, his preference, will be kept in mind as much as possible because for him, that's where his quality of life is. And so this is where we see where palliative care, advanced medical directives are intertwined with care. And so when people say, what is palliative care? Well, this is part of what palliative care is having these open and honest conversations about where would you like to live the best days of your life in the future? Where do you see yourself? Where does your family see you? What kind of care needs will you have, et cetera, et cetera. And so again, going along with this adapted care, they adapt his services at home, ideally receiving psychosocial, emotional, and practical support for the caregivers and the family that are caring for him, and adjusting the care plan according to the deterioration that the illness will cause in this particular situation or in any other situation. So that's where we see the parallels of the illness and the advanced medical directives, because at this point in time, he's able to express some of the values that he feels is important to him, his preferences and that of the family. Is the timing at this point advanced medical directive oriented? Possibly not, but he already did this, as we saw in a previous slide. So he already has that as a background. This would be further along in terms of his preferences and making sure that those ideas and values and choices still stand firm for him and his family. We move in. Yeah, go ahead.
Sorry.
No, I'm
So,
just moving along.
okay, good. We're in sync. The other form that we like to present to you is level of care. If you go on the INES website, it was the Institut National d'Excellence en Santé et Services Sociaux. So it's a big acronym. So you just Google INES, and if you look at the level of care, there's a this document that exists. It's a flyer that exists in French and English that explains what are the level of care. So there was an issue in the healthcare system. Every hospital had different type of level of care. Some were using letters, some were using numbers, some was using 1, 2, 3, 4, some was using 1A, 1B. So there was like a mishmash of different level of care in different hospitals. So the government, to kind of reset the level of care across Quebec, they did a study and they did what would be best to simplify different level of care. So now in Quebec, every healthcare establishment should use the INES level of care. And level of care are objectives that you set with your treating doctor to see what type of care you would like, or what type of intensity of care would you like, and also what type of care setting that will be able to meet your need. So let's look specifically the A, B, C that the NES kind of put together. So level of care A, it's all treating, all medical intervention that will prolong your life. It could be very active, very aggressive. It could be different type of treatments, and you can imagine all the different treatments that's possible that could help to save your life and bring you back to life and prolong your life and hopefully recover from your disease and your event. It could be an accident, it could be whatever, an illness that strikes you. You know, you agree to have all the care possible under the umbrella to save your life and keep you on going and hopefully resume your level of activity that you had before. Level care B is more like, okay, let's prolong life, but let's set some little bit of limits in terms of what you want. And the doctor is able to kind of write on that form the different limits you want to have. So you may decide, okay, give me everything possible, but if it's to have a CPR or a cardiac resuscitation process done, that I don't want, then that could be level B. And the doctor will write in the comment area, do not provide CPR, but do all the other care that's possible to keep prolonging the life with some limits. Level C in these a bit more, it's a bit easier. You know, level C, it's aiming at comfort care as opposed to, so more quality of life that could maybe lead to a situation where the patient may require palliative care at this moment. So comfort care is more in terms, let's start looking at palliative care, introducing palliative care team to make sure that the patient's signs and symptoms are better managed. And when I talk about palliative care, it means I talk about palliative care. People also very often associate palliative care with cancer patients, but it could also be for any disease. It could be for Alzheimer's, it could be for Parkinson, it could be for any chronic disease, advanced chronic disease, where a patient is not responding to all the traditional treatment, and the only thing that could be aiming at is comfort care. So that's the objective that you would set with your specialist or your family doctor. And level care D, of course, well, then there's to a point that the patient is not responding to any medication or treatment. And really, it's the comfort care and it's more quality over quantity of life. So really, if it's making sure that you get a bit more pain management, we may provide you a bit more sedation, but the aim is really to provide comfort and pain relief. So that's really more in terms of level D. Level D. You can still get some, of course, signs and symptoms support with the level C, but the level D, it's really at the end tail of the disease where the effectiveness of some treatments are compromised and where the patient's really looking at, okay, let's do some distress protocol, which are treatments that are put for patients that are suffering advanced lung problems and making sure that they're able to breathe, that they're comfortable, and their anxieties are better controlled. So that could be offered with the level D at the end of life. So this is the different order of intensive care. Of course, level A, it's very much could be offered mostly in a hospital setting where they have access to all the different care and diagnostic tools. Level B, C, D could be offered anywhere else. But if you need some resuscitation, in some nursing homes or at home, they may start a maneuver and they may call 911 to transfer you to the hospital to get some other type of treatment to deal with your heart failure. So that's also to consider in the level of care and also where the care can be provided. So we wanted to show you the form that the physician have to fill. So the physician, it could be your GP or a specialist, they're going to set with you the different level of care. So at the beginning, they have to assess your level of competency, if you're able to respond, or who's answering those questions for the person that's not able to consent. So if you're the spouse, or if you're the mandatory, or if you're a public creator, could also answer to those questions in terms of, okay, what's the best level of intensity of medical care provided. Then they have to ask if you have advanced directive, or if you have a living will that you said before. So that'll be considered in the conversation. And then after the discussion with the physician and the patient and hopefully the patient and the physician will come to an agreement in terms of what's the best level of care. Patient could be like my father-in-law mentioned. He wants a level A, but maybe his cardiologist said, well, your heart condition is more advanced, and you should go for C. But if the patient wants level A, then the doctor will write level A, and in the comment area, the doctor may write, well, according to my medical assessment, patient should get level C, but wants level A. Please discuss the situation at his next hospitalization. So the doctor could personalize also the differences of opinion between the physician and between the doctor, and sometimes the family members are part of that discussion in terms of where they're at in terms of the evolution of the disease and their comprehension of the disease and the phase of the disease with the level of care that would be required, and the location of care, of course, that could be impacted with the decision that you make. So it's really a discussion that could be held. At the end of the form, it's a physician that has to sign the level of care. Of course, the treating teams, either at home or the hospital setting, could encourage you to have the discussion with the physician. Myself, as a social worker, I'm not a physician, but I often have the discussion with my client at home to discuss, okay, what type of care you would like to have in the future, what type of what you're aiming with. Are you trying to aim for a full recovery? Do you think that your disease is at the beginning stage or more towards the end of the disease? So I have that discussion, and I help the patient to make sense of, okay, where they're at in terms of the disease, and help the caregiver to also collaborate and be on board with the level of care. Because at home, who's going to call 911 if the patient has a heart arrest is the caregiver. So it's very important that all parties on board are in sync. So the physician, the patient, but also the caregiver, to make sure that the right decision is made and that the care provided is appropriate according to the wish of the patient, but also according to his comprehension and what's medically wise to request. So that's something to set, and it's kind of a guiding principles that of objective care that the physician wants to reach, and making sure, okay, what type of intensive care you want at the stage of disease you're at. So it could change over time. You could be A, you could be B, and some people are B, and then and they say, okay, I'm getting chemo because I have a cancer, and I may want to be level C, and then you go through the course of chemo, radiation, and your cancer is well controlled. It's well maintained, and after a few years, you're in full remission, and the cancer is gone, and you may decide, okay, well, since my cancer is cured, let's aim at a level of care A. So you can be put back at level A. So what I'm trying to explain is the level of care can be changed according to the progress of your medical situation, and also not just the dementia element, but also the other physical component of your file. So that's why it's signed with a physician to really assess where the patient's at, and to have that open discussion where the patient's at. So yes, it's a medical decision at the end of the form, but it's also a comprehension where the patient's at and what care they should require. So this is pretty much the end of our presentation today. So we have a few minutes if you have some specific questions in terms of level of care. This is an added element, but we felt, Zelda and I, that we should present it because very often caregivers will be confronted when a patient goes to ER, okay, and the treating team or the ER doctor, ER nurses may ask, well, what was this level of care? What type of care you want in the future? And especially with somebody with dementia, being in the ICU or ER, they could be disoriented, not able to consent, or not clear in terms of what they wanted. And the caregivers will be called and say, well, what's the status? What type of discussion you had? So it's good to know that level of care exists, and it pertains to the intensive care that the patient will have.
This information is, we understand and we can appreciate that it's a lot of information at one time, and you may have a lot of questions around, the technicalities of it, the criteria of it. And we'll talk a little bit more about palliative care next week. And, we were trying to fit it in a little bit today, but we'll talk a little bit more specifically about it next presentation, as well as medical aid in dying. We'll go into more detail about that. But if you have any questions at all that sort of linger from this presentation to the next, please keep those questions and we will certainly try to address them. Perhaps we'll save some time right at the beginning of the presentation so we can recapture some of that and then continue on with the rest of the presentation that we have planned for you. Thank you for sticking with us during this, all of this information, and hopefully we've left you with some food for thought and some good information to follow up on for your particular situation or someone else that you know. I'll pass it over to Rennie.
Thank you. So thank you so much, Zelda and Patrick, for such an informative lecture. And I think what are some very challenging and very relevant topics. And, I think it's a great idea. We can take some time next session if people have questions in the intervening time. I just, want to make a few little housekeeping notes before we go. I just want to let everybody who's attending know to keep an eye on your email. You'll be getting the slides that our presenters have showed us today, and you'll also be getting a survey. Please do give us at AGI your honest, anonymous feedback. The survey will also allow you to give us your input about what different topics for lectures that you'd like to see in the future. And please join us again on April 22nd for the second part of this lecture. And, if you have any further questions or there's anything on your mind related to what we've spoken about today or related to the experience of being a caregiver or, of having or knowing someone with dementia, we do encourage you to connect with an AGI counselor either by phone or by email. That's always open to you. So thank you, everybody. And thank you to our two wonderful presenters. And we look forward to seeing you in a month's time.
Thank you.
Thank you.
Take care. Stay safe.
Yes.